A 74-year-old man, acute right-sided weakness, face, arm, and leg. Where is the lesion? By the end of this video, you'll be able to localize this to within 1 centimeter of the nervous system. Pretty remarkable. This is a spiral neuroanatomy curriculum. We start with a simple map of the nervous system, and with each pass we go back to the beginning and get deeper and deeper until you can localize anything. You don't need to have started from the beginning to follow this one. Everything you need is right here. So let's go back to that man with the right-sided weakness. So he has right face, right arm, right leg, all weak, all the same degree, and no sensory loss at all. So this is a pure motor problem. That tells us to start with the motor pathways. Let's follow a single motor signal from the moment it leaves the brain. Now, as always, please excuse my horrendous drawings. So we're going to start off right at the top of the cortex. So if I was to draw the brain in what we would say is a coronal view, so if I was to put a crown on my head and slice it through the front, that would be the coronal view. So we're looking straight at the brain here, and this is the frontal lobe. So this is going to be the center of the brain, and we'll just put a little dotted line there. And we have our left and we have our right side. Primary motor cortex is a gyrus that runs around like this. So you already know where this starts. It's the primary motor cortex, the gyrus we just mapped out in the cortex episode. It's in front of the central sulcus in an area we call the precentral gyrus. And you already know these cells. They're the first order neurons, the upper motor neurons that we met in episode 2. There's one detail worth adding now. The body is laid out along this strip in a fixed order. We call it the homunculus, the little man. The neurons that start here will go to these parts of the body and innervate them. Now the face and actually sits down here at the bottom. So let's draw the eyes. Let's draw the nose, and let's draw the mouth. Above that is the hand. And then we have the trunk, and the leg part actually comes down around here. Beautiful. Picasso would be proud. Now, the parts you use with precision, the hand and the face, take up a huge amount of cortex because there's a lot of neurons that are required to move those parts, whereas the trunk and the leg have far less. So the map is distorted, a giant hand, a giant face, and a very small body. Now, here's the idea for today. At the cortex, these fibers are spread out. They're wide. That whole homunculus, from the face down low all the way to the leg up high, is stretched right across the strip. So if we were to draw the nerve fibers, really they would be coming across all the way like this. But as they descend, they pull together and they form a funnel from a wide sheet at the cortex into a tight, dense bundle. The place that they're most tightly packed over here is the internal capsule. This is the internal capsule, a narrow channel of fibers threading between the basal ganglia and the thalamus. So if we were to draw these two structures, we'd say basal ganglia here, and let's just say thalamus here. Basal ganglia. So those are other subcortical structures below the cortex that we marked on our map early on, and we'll come back to them and give them a whole episode later in the series. But for now, all you need to know is that the internal capsule runs right between them. Now, if we go a little bit deeper, the internal capsule has 3 parts. And if I was to just draw what we would say is an axial view of the brain, so looking from the top down, so I'm going to label this coronal, and we'll label this axial. So if we look from an axial perspective and we look at the fibers, they're coming from the primary motor cortex down, then they're getting densely packed into the internal capsule. We have our basal ganglia at the front, and we have our thalamus at the back. And the internal capsule threads through in 2 different ways as it makes its way down. So we'll say basal ganglia here, and we say thalamus here. It threads down in the anterior limb, in the posterior limb, and then the genu. So the genu just means the knee, and we have the posterior and the anterior limb. Now, the motor fibers specifically run through the posterior limb and the genu. So right here, when we're describing this in the internal capsule, as it threads through here, this would be the posterior limb of the internal capsule. As all those motor fibers are densely making their way through, that's the posterior limb of the internal capsule. And then it turns to the genu. So when we get a lesion in the posterior limb, that's when we get that pure motor involvement. Now think about what that means. At the cortex, a stroke takes out a small area. You lose the hand, but maybe the leg is fine. The fibers are spread out. So a small lesion only catches a few of them. But in the internal capsule, every motor fiber in the entire side of the body is squeezed through a space a few millimeters wide. One tiny lesion here, one small blood vessel that strokes out, and you knock out the entire face, arm, and leg at once, and it's incredibly dense. But I want to keep following these tracks down because the pathway picks up a different name at each level, and this can sometimes trip people up. So I want you to see this all as one continuous tract. So as these fibers keep coming down, they make their way into the brainstem. So these structures here are cortical. We've covered that. This is a subcortical below the cortex. And now we're going to enter the brainstem. So at the cortex, the fibers fan out in a spray. That spray has a name. The corona radiata, the radiating crown. And so that sits here in this spray. So if we were to go here, we'd call that the corona radiata. It's still not as densely packed. It's still a spray, a crown of radiations. Then they gather themselves in the internal capsule. Same fibers, new name. Below that, when they enter the midbrain, running through a structure at the front, that is called the crus cerebri. I'm just going to label this brainstem, and specifically midbrain, pons, medulla. These are the three parts of the brainstem that we'll go into more detail. So in the midbrain, it's called the crus cerebri. Then in the pons, as they pass through, and again at the front of the pons, it's called the basis pontis. At the base of the pons, hence the basis pontis. And then down in the medulla, they form the pyramids. And they're called the pyramids there. And that's where the term pyramidal weakness comes from, the pattern we covered back in the upper motor neuron episode. Weak extensors in the arm, weak flexors in this leg. And this is the structure that they're named after, because when you look at the brainstem, when you look at the medulla during dissection, it looks like pyramids, so they say. And now if we go a little bit further down, we're now in the spinal cord. And in the spinal cord, there's no particular name for them, but we just call them the cortico-spinal tracts. Cortex to spinal cord, corticospinal. And really that's the name of the whole pathway. Everything above was just a local label for the same fibers passing through it. So one track, 6 names: corona radiata, internal capsule, crus cerebri, basis pontis, pyramids, corticospinal tracts. Think of it like a single road, like High Street Road, but it passes through a different suburb. Every time it goes into a new suburb, it gets a new name, but it's High Street, then Toorak, and then Burwood, or whatever you want to call it. It's the same road, but it just changes name when it enters a new region and a new area. And it's a similar thing that's happening here. Now, 2 more things happen on the way down, and both matter for localization. So the first is decussation. That means crossing over of the fibers. So this happens down at the bottom of the medulla. So right here, down in the lower part of the medulla is where the fibers for the corticospinal tracts cross over from the left side to the right side. And so that is why the left primary motor cortex controls the right side of the body. The signal crosses over here at the lower part of the medulla. So our patient with right-sided weakness, the lesion is on the left-hand side. The second thing is where the first order neurons actually end. We touched on this back on the episode of upper versus lower motor neuron signs. So the fibers heading for the face, they actually peel off in the brainstem and synapse onto the cranial nerve nuclei. That branch, cortex to brainstem, that's called the corticobulbar tracts. The fibers heading for the arm and leg, they keep going all the way down into the spinal cord, and they synapse onto the anterior horn cell. So that's what we would say the corticospinal tract proper. At both of these points, the cranial nerve nuclei and the anterior horn cells, the first order neurons hand over to the second order neurons. So once again, we're recapping here. So if you haven't seen this episode, always feel free after this one to go back and watch it. The second order neurons, which we call the lower motor neurons. And that is the cell that actually runs out to the muscles. So now let's go back to our patient and work him up properly. A real case, history, then examination, and then we can localize it. So history, we got a 74-year-old man, sudden onset while he was eating breakfast of weakness down the right side, face, arm, and leg. No headache, no loss of consciousness, sudden, painless, all at once. Now on examination, he has a right facial weakness, right arm and right leg weakness, all dense, 0 out of 5 power, all equally the same, and there's no sensory loss anywhere. And critically, there's no cortical signs. His language is normal, no neglect, no visual field defects, he's alert and he's oriented. On the limbs, the plantars are upgoing, but the tone is flaccid and the reflexes are reduced. Now hold that thought because it looks contradictory, but it's the first thing I'm going to explain. Okay. So now let's localize, and we do that in the same order every time, the way we built across this entire series. So what is the most important question in all of neurology? And the question is it central versus peripheral? And we can focus on the motor nerves and the motor examination to do that. So we look at tone, power, reflexes, TPR. Now when we look at these examination findings, we see flaccid weakness, so the tone's down, the reflexes are reduced, and that sounds peripheral, lower motor, but the plantars are upgoing, and that's an upper motor neuron sign. What we're dealing with here is spinal shock. Never forget that. In a sudden, severe upper motor neuron lesion, the classic upper motor neuron picture of increased tone, brisk reflexes, that takes time to appear. In the first hours to days, you get flaccid weakness, reduced reflexes instead, and that is a sign of spinal shock. But this patient has an upgoing plantar, which is an upper motor neuron sign, which means this is central. Second question, longitude. How high is the lesion? So we have face, arm, and leg all involved, all on the same side, and that tells us that the lesion is above the brainstem. Below the brainstem, we wouldn't see any face involvement, and in the brainstem, we would see cross signs, so face on one side, body on the other. We'll go into that in more detail when we do the brainstem episode, but for right now, everything on the same side, face, arm, and leg, that's above the brainstem. So how high? Well, the cortical signs matter. There are none. And we are told that in the case. No aphasia, no neglect, no field defects, fully alert. Now, if this was a big cortical stroke, let's say a large MCA, for instance, taking out enough cortex to give dense weakness of the face, arm, and leg, then we would almost certainly see some cortical dysfunction. You expect an aphasia, and language dysfunction, neglect, field deficits, everything we talked about in the previous episode. The fact that everything motor is gone, but everything cortical is intact tells you that the lesion sits below the cortex in the subcortical region. So if we go to our map, it's going to be in this subcortical region here. Now the final question, latitude. Within those deep subcortical regions, where exactly? Now there are three candidates here. The internal capsule, the thalamus, and the basal ganglia. Well, it's going to be the internal capsule for two reasons. First, this is where all the motor fibers are densely packed together. Secondly, I haven't taught you about the other structures. Why would you pick that? Okay, so back to what we've talked about this entire lesson. Pure motor, dense, whole side, nothing cortical. That is always internal capsule until proven otherwise, and very specifically the posterior limb of the internal capsule. Perfect. You localized it within a centimeter just by staying logical and reading the map. And next week we stay deep, but we move just behind the internal capsule to a structure almost every single signal in your body has to pass through. It's the great relay station of the brain. Next week, the thalamus. Now, if this has helped you in any way, then please subscribe, turn on your bell so that you can catch the thalamus episode next week. And if you're new here, go right back to the first episode and start the series. Everything builds from there, and you'll watch your localization get sharper and sharper with each episode. Send this to someone in your year level who's still trying to memorize syndromes and get them to actually understand what's going on. I'll see you next week.